Welcome to Renalogic's presentation of carving out benefits, empowering self-funded employer plans against predatory dialysis pricing. I'm Scott Gold. I'm Renalogic's Chief Commercial Officer. I am joined today by Dr. Eric Bricker and Richard Jones. Let's introduce ourselves. I'm Chief Commercial Officer of Renalogic, responsible for new client acquisition, sales, marketing, and all kind of client-facing activities. I'll turn over to Eric to introduce himself.
Hi, everybody. I'm Eric Bricker. I'm a general internist. I went to medical school at the University of Illinois, residency training at Johns Hopkins in Baltimore, then went on to practice with the Baylor Scott and White Hospital System here in Dallas, where I'm located. I've probably treated hundreds, if not thousands, of chronic kidney disease patients. And I also founded a healthcare navigation firm called Compass Professional Health Services that worked with over 2,000 employers, about 1.8 million people. And at Compass, we also help thousands of chronic kidney disease patients navigate their health insurance and the healthcare system. And then finally, I started these A Healthcare is the Healthcare Finance videos. I've got about 400 of them, about 1.3 million views last year. Many of you have probably seen the videos. So I appreciate you all being here today.
Thank you, Eric. Welcome. Richard.
Hey, everybody. Pleasure to be here. My name's Richard Jones. I currently reside in North Carolina, but have lived in a variety of locations around the country. I've been in this industry for about 19 years in the risk management and health benefits strategy consulting business. Prior to that, I have a strategy consulting background, and my focus is on middle market clients. So primarily self-funded clients in the 200 to 5,000 employee size. And so most of my comments today and my experiences are going to be in reference to clients in that size space. So look forward to being here and to sharing what I can.
Yeah, thank you both for participating. Really appreciate it. So before I dive into the agenda, just a few housekeeping matters. As you heard, to start things off, this webinar is being recorded. So I hope you take copious notes, but in the event that you miss something, we will redistribute this. So if you're on this webinar or you registered, we will send around a link to it. You can access it from our webinar and even share it with your colleagues or clients or those that you believe would benefit from it. Everyone is muted or should be because this is in webinar presentation mode. If you have questions or comments, please submit them through the question feature in the application, the Zoom application. We will field questions at the end of the webinar, time permitting, although we budgeted a significant amount of time for questions. Our intention is to get to all the questions we can in the time allotted. To the extent we can't, we will follow up afterwards with answers. So I encourage you to use that feature. And then lastly, we'll take 2 polls throughout the presentation just to get some feedback from you all about how you are working with or evaluating carve-outs. For today, we're going to start this presentation just with a quick overview of the dialysis services market in the United States. This will help frame or ground the conversation in kind of the current state of affairs. And then we'll go through the 6 inalienable rights of health plans, of self-funded health plans, to carve out high-cost high-cost claims to manage kind of extreme costs from these benefits. And then, as I said before, we'll take some question and answer at the end. So with that, let's turn it over to Eric. Eric, can you please help us understand kind of the state of affairs in the dialysis services market in the United States?
Yeah, happy to. And the Renalogic has put together some fantastic slides here. So I'm actually going to read a fair amount of the content that's actually on the slides. So first off, with dialysis, it's super important to know, starting on the left, that there are 2 public companies that control 85% of the dialysis facilities in America. And those 2 companies are DaVita and Fresenius. Now, DaVita is a publicly traded company, and believe it or not, its largest shareholder that owns 30% of this company is Warren Buffett and Berkshire Hathaway. Okay. Now, next, Fresenius is actually a German company. Now, there used to be an American company that was a huge dialysis group, and then Fresenius, this German company, bought them. So that's how this German company got into the U.S. dialysis business, because it's so lucrative. Now, when you have commercial insurance, when you have an employer-sponsored plan, these two companies are charging between 700% and 1,200% of the Medicare rates for dialysis services. So in other words, 7 to 12 times what Medicare pays for dialysis. It's upwards of about $2,500 to $3,000 per dialysis session. And when somebody has end-stage renal disease and is on dialysis, they got to go 3 days a week. And they typically go Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So you're talking upwards of $6,000 to $7,500 per week. And it's 52 weeks a year. You go year round. Okay. Now, dialysis costs have increased 400% since 2008. And employers pay almost $100 billion for dialysis-related costs annually. And I don't mean to be all doom and gloom, but the trend is for it to get worse, because kidney failure has increased 1,300%. In other words, 13x since 1980. Why? Because the number one cause of kidney failure is diabetes. So with the dramatic scourge of diabetes in America, we've had just this exponential growth of kidney failure and then the associated dialysis. Next slide, please.
Yep.
And so DaVita and Fresenius essentially engage in a zero-sum game where their win is an employer-sponsored plan's loss. So all employer-sponsored plans in America with commercial insurance have an X on their back, and DaVita and Fresenius are going after them. And this is, if you look in the little small print in the bottom right-hand corner of the slide, this is from DaVita's annual report from 2022. So you're going to hear this. This is not an Eric Bricker opinion. You're going to hear this straight from the horse's mouth. Okay, I'm going to read this. Okay, so this is from DaVita to their shareholders. This is the first box. A substantial portion of our U.S. dialysis net patient services revenue for the year ended December 31, 2020, was generated from patients who have commercial payers as their primary payer. The majority of these patients have insurance policies that pay us on terms and rates that are generally significantly higher than Medicare. They admit to it. As such, our revenue net income levels are sensitive to the number of our patients with higher paying commercial insurance coverage and the percentage of our patients under higher paying commercial plans relative to government programs. In other words, the more commercial folks that they have, the more money they make. The payments we receive from commercial payers generate nearly all of our profit, and all of our non-acute dialysis profits are from commercial payers. Okay, Warren Buffett makes money off of employer-sponsored health plans' backs. Okay, they are going after employer-sponsored health plans' money. Okay, second box. When traditional or original Medicare becomes the primary payer for a patient, okay, what does that mean? So the way that it works is there's this thing called a coordination period, where when somebody first has to go on dialysis, Medicare doesn't kick in for a minimum of 30 months. Okay, so Medicare, the person eventually becomes disabled. Eventually they go on Medicare, but it's almost 3 years that a commercial plan has to pay for it. So DaVita is saying during those 3 years that commercial insurance pays us before Medicare kicks in, that's where all of our profit comes from. I'm going to go on back to the paragraph. The payment we receive for that patient decreases from the employer group or commercial plan to the lower Medicare payment rate, right, after the coordination period. If the number of our patients who have Medicare or another government-based program, it's just Medicare, they don't really mean another one, as their primary payer increases, it could negatively impact the percentage of our patients covered under commercial plans. In other words, they don't want people to go on Medicare. They want them to stay on their commercial health insurance plan. The final box, the icing on the cake. If the number or percentage of patients with higher paying commercial insurance plans declines, if the average rates that commercial payers pay us decline, if commercial plans subject patients to restriction in plan designs, or if we are unable to maintain contracts with payers with competitive terms. By the way, the word competitive here means lucrative. With payers with lucrative terms, including without limitation reimbursement rates, scope, and duration of coverage and in-network benefits, it could have a material adverse effect on our business, results of operations, and financial conditions and cash flow. Okay, so employer-sponsored health plans are the cash cow for DaVita and Fresenius. This is not an Eric Bricker opinion. They admit to it themselves. Next slide, please.
Yeah, I appreciate that. Thank you. Richard, what are you seeing from stakeholders in the ecosystem?
Yeah, I mean, just hearing Eric's passion, it gets you fired up thinking about this system. It's so broken. Just building on what he was saying about the incentives, we have actually seen a number of cases where folks who are have end-stage renal disease, who are going through dialysis multiple times a year, maybe on COBRA, and they get to that point in time where they should transition to Medicare. And actually, these two companies, through various foundations, are paying COBRA premiums for those COBRA participants to stay on COBRA rather than move over to Medicare, so they can continue to collect those higher reimbursement rates. It's really frustrating. As the title of this slide suggests, the market is just not very well equipped to handle this. It's something that, frankly, a lot of employers aren't aware of. I think what happens behind the scenes, they may see the high claims, but a lot of the time it's too late at that point. That's one of the things I would point out, in the inefficiencies. Today's webinar is primarily about the dialysis claims and what you do when you have patients on dialysis or members on dialysis. But the fact of the matter is, the ecosystem should be doing more to even prevent them from getting there, from allowing those disease states to progress to the point where they do have ESRD. So, the typical networks do not have significant discounts for these services. So, as has already been stated in those company public releases, the strategy is to cost shift, to charge employers who are funding the insurance programs, mostly self-funded and in some cases fully insured programs, to have them pay those higher rates. There are some options out there like reference-based pricing, but those strategies, that strategy comes with some problems. I think we'll talk a little bit more about that as we progress here in today's program, with balanced billing and potential lawsuits. So it's a broken system. And as an employer, there are things you can do, but if you are not intentional about it, you're unfortunately going to see these significant claims.
Yeah, point well taken. When you do find a solution to help one of your clients contain costs, in this case, high dialysis costs, how do you find that other stakeholders like the TPAs, the networks, or the ASOs, how do they react? What are you seeing in the market?
Yeah, so keep in mind, I always like to think about the incentives that are driving behavior. So I think those public releases are very compelling. So their incentives obviously are to maximize their profit. The TPA, third-party administrators, what TPA stands for, ASO, administrative services only, these organizations are not taking on any risk. They have no incentive to save employers money. They are simply processing claims. So when we are trying to work on behalf of our self-funded plans and employers to minimize these costs, we often run into headwinds. We either run into administrative challenges of, gosh, we can't allow you to carve that out. We oftentimes have trouble seeing data. The pricing can be very difficult to determine. Sometimes these claims are sent through in batches and bundled so that, if they're going 3 times a week, we may see a week's worth or a month's worth of claims at one time. And then when we do get data, oftentimes the carriers, TPAs, will add significant data feeds, file feed charges, or data extraction charges that makes it very expensive to try to obtain the data to make good decisions and design good strategies.
Yeah, no, it's a really good point. Eric, why do you think, I mean, Richard's point about kind of misaligned incentives and no incentive to save money is a salient one. Why do you think that, if you can amplify that, these stakeholders are taking those positions? Why are they making it difficult for data blocking or data sharing?
Yeah, so it's a great question. Like, why is this happening, right? Every TPA and ASO, when they approach a self-funded employer, they're like, we're going to help you with cost containment. I mean, that's one of the things that when they come to you, but to Richard's point, but they're not taking any risk. So why is the TPA or ASO not being as cooperative? Because they're not sharing data. They're blocking some other things that we're going to get into. Why would they not cooperate more with the employer? It almost seems like they're cooperating more with DaVita and Fresenius. Why is that? Okay, now it's a little complicated, but kind of hold on with me. Unfortunately, it has to do with Medicare Advantage. What? This is a commercial webinar. Why in the world are we talking about Medicare Advantage? Okay, so you got to understand that all the major carriers make the majority of their money, not through commercial insurance, but from Medicare Advantage. Okay, Medicare Advantage and Medicaid government programs is the cash cow for United, for Blue Cross plans, for Cigna, for CVS, Aetna. Okay, it is their cash cow. They make it, it's their cash cow because they receive huge sums of money from the government to cover a Medicare person, and then the insurance company is at risk. And when they have a contract, so they have a Medicare Advantage contract with a hospital or physician or dialysis, guess what those contracted rates are? They're essentially the same as Medicare. Okay, so a commercial insurance rate for a Medicare Advantage plan is not the same as a commercial rate for an employer-sponsored plan. They're totally different. So when the insurance carrier sits down and negotiates their contract with any provider, doctor, hospital, dialysis provider, the provider's looking at the total contract value. They're literally, the hospitals do this. They're like, we need to be paid about $4 billion a year by you. Okay, so we're going to figure out how to get to that number, but you need to pay us $4 billion. Okay, their Medicare Advantage stuff, their fully insured stuff, their self-funded stuff. Okay, so what they do is they say, okay, well, listen, we need to keep our Medicare rates for our Medicare Advantage contracts so that we can, insurance carriers make more than twice the profit margin on a Medicare Advantage member versus a commercially insured member. So not only is it a higher growth area for them, it's a more profitable area for them. So fine. So any provider, hospital, physician practice, dialysis provider says, fine, if you're going to do Medicare Advantage at these really low Medicare rates, then you gotta give us something somewhere else in the contract. You gotta give us a chunk of lives where frankly you're going to pay us a ton more so we can get to that $4 billion a year number that we need to get to. And they said, aha, we'll give you our self-funded lives. We're not at risk for them. Oh, that's great. So what they do is they say, okay, we'll pay you 12 times what we pay you for our Medicare folks, for our commercial folks, because for the self-funded folks, we're not at risk for them. And that is the business model. We see that, and it's not just in dialysis. That's the whole reason why the hospital allowed amounts are 5, 7, 10 times the Medicare allowed amounts, because they're doing the exact same thing on the hospital side. So that is their business model. And so for them to then go against that business model, in other words, to actually do what would be your, in the employer-sponsored health plan's advantage, it screws up that whole negotiation tactic that they used with the provider. So I hope you follow that, because it's complicated, but that's how it works.
Yeah, listen, I mean, if there's one truism about healthcare and healthcare insurance in this country, it's that it's complicated and it's cross-subsidized. And so I think you raised an extremely important point. And I think we're seeing some self-funded plans stand up and say, wait a minute, like I need the data to understand my level of subsidization, whether I'm getting screwed, whether I'm paying too much. And you see this in the Kraft Heinz case. in district court in Texas against Aetna, or the Owens and Minor case against Elevance in the Eastern District of Virginia, or the two labor union cases in Connecticut against Elevance, or the pending litigation against United Healthcare, we're seeing health plans kind of stand up and say, either enough is enough, or the obfuscation has been too much, and I need my data to understand whether I am paying my fair share or more, or whether there are these kind of backroom handshake deals. So fascinating points, and I appreciate you articulating them for us. Let me move to the next one. So fortunately, self-funded plans have inalienable rights to control their own high-cost claims or their own benefits, particularly dialysis. Like, there is a way to fight back, and that's because since they are self-funded plans, to Eric's point, they assume their own risk, right? They are on the hook. They are fiduciaries for their own plan assets, their own plan members. They're able to determine the benefits they provide. And so under federal law, under ERISA and under HIPAA and under the ACA and some other statutes and frankly case law, they've been afforded wide latitude and flexibility in kind of designing their own benefits. What's critically important is that under federal law and basic contract law, contract principles, third parties, so the TPAs, the networks, the ASOs, are required to take the plan's direction from the plan sponsors when it comes to the content of the plan documents and how benefits may be carved out and paid. Not for the third party stakeholders to dictate what goes in the plan documents. It's for the plan sponsors to control their own plans. And so what we're going to do next is kind of walk everyone through these 6 inalienable rights to control dialysis costs through carve-outs. But before we do that, I want to take a quick poll. So I will throw this poll up here. Poll question 1, which is, based on your current, and maybe I'll move it over here, based on your current understanding, how would you rate your ability, those that are listening, to navigate and enforce the legal rights to control dialysis benefits against Big Dialysis's predatory pricing? We'll just give it a few minutes here, or a minute or two, as people are responding. Scale 1 to 10, 1 being very poor, you don't have a great understanding and a great ability, and 10 being, you or your clients believe yourselves to be firmly in the driver's seat. As we're coming in, just a few more minutes here, or maybe another minute here. All right, people are clicking through. I will end the poll now, and let me share the results. Let's see here. So what we're seeing that is here, 20% of you, let's call it, 34, 30, 40, basically 40, almost 45% of you are, don't think you have any real ability to control. There's very few of you who really believe that you're kind of firmly in the driver's seat. Hopefully, what will happen is, through today's a webinar, we will arm you with the knowledge, right, that you need, the information that you need to assert more authority and to help guide yourselves or your clients through the gauntlet and begin to carve out these benefits, take more control over the cost for predatory dialysis pricing and other things. All right, so let's start. Eric, why don't you walk us through this first right here?
Okay, so again, slides are super helpful with information, so I'm going to go ahead and read this one. Okay, so 1, self-funded plans have the right to carve out their dialysis treatments. Okay, federal law exempts self-funded plans from most benefit mandates and all benefit mandates under state laws. Okay, this means they can adopt cost-effective benefit designs that provide for alternative administration and determination terms for high-cost treatments, like dialysis. So the Supreme Court of the U.S., oftentimes abbreviated SCOTUS, firmly entrenched this right to carve out dialysis treatments in its Marietta Memorial Hospital et al. Versus DeVita et al. Decision. Okay, so very briefly, this decision just happened in June of 2022, okay? And it's a huge win for employer-sponsored plans and self-funded plans, okay? So it's relatively new. It's like barely over a year old. And of course, there's not going to be like big headlines about this, but just Google this. There's actually really very good plain English summaries of this court case. It's very easy to understand. So Marietta Memorial Hospital, it was for their own employees. It was for their own, like, you know, nurses and techs or whatever, or their family members that were on dialysis. And they were like, look, we're not going to pay out this like ridiculous rate that our carrier wants to do. And so DaVita was like, no, you better do that. So DaVita sued them. And it went all the way up to the Supreme Court, and DaVita lost, and Marietta Memorial Hospital won. And the Supreme Court was like, yeah, you can totally carve out your dialysis benefits and change the way that you reimburse, as long as you apply it to everybody else in your plan the same way, which of course they did. And so, I mean, I think the most important thing here is this is a new ruling that totally helps you as an employer or as a broker benefit consultant in regards to legal precedent for carving out dialysis benefits. Okay, so third parties, TPAs, ASO, PPOs, have no right or authority to dictate to self-funded plans the contents of their plan documents. Now, oftentimes they like quote unquote help, right? Surprise, surprise, but you don't have to take their help. Okay, you are independent. You can write them however you want to write them. Simply put, TPAs, ASOs, and PPOs have no authority to refuse to allow self-funded plans to adopt dialysis carve-outs. And there was a question in here, and of course, they will always push back and say no and not want you to do it, okay? So the assumption should be they're gonna say no, they're gonna make it hard, they're gonna come up with a gazillion reasons why you can't do it. Okay, so that should be assumed. They're like, hey, we wanna carve out our dialysis. They're not gonna go, oh, that's great, we would love for you to do that. They're not gonna do that, okay? So it should be assumed that they are going to try to stop you. Now that doesn't mean they stop you, but they're gonna try. Next slide. Okay. 2, self-funded plans have the right to their own claims data and the right to share it with cost containment partners. Guess what? Some employers get like zero detail or very little detail about their dialysis kits. Okay, we've got Mary going 3 times a week. Can we see what Mary's cost per session was? No. Can we see how many times Mary went? No. You've got to be kidding me. You have fiduciary responsibility to your plan members, and you have hired an ASO or a TPA who will not give you the basic information of the cost per dialysis session and the number of dialysis sessions. That's right. And guess what's happening? This is where, like, as you saw on the news, Heinz Ketchup is suing Aetna for exactly that type of data. They're like, you have no right to block us from having that. Okay, a self-funded plan has the right to obtain claims data. Again, the carrier is going to say no. Okay, so the expectation is they're going to say no. They're not going to be like, oh, we'd love to give you our claims. No, they're never going to say that, okay? But can you still get it? Absolutely. And we're going to talk about various, and of course, this is like part and parcel to Renalogic's methodology to help you through that, but you absolutely can do that. Okay, so a self-funded plan has the right to obtain claims data from a TPA, ASO, or PPO based on fundamental property and contract principles and ERISA and HIPAA. Okay, as the owner of and party responsible for its claim data, a self-funded plan has the right to share its claim data with service providers, including cost containment partners for plan payment and healthcare operation purposes. Last bullet, TPAs, ASOs, and PPOs have no authority to refuse to provide or forbid a self-funded plan from sharing that data. Gag clauses or erect barriers to make it artificially difficult or costly for a self-funded plan to obtain such data, such as charging fees, delaying data, etc. Now, keep in mind that there are absolutely fiduciary risks that under the CAA are much greater than they used to be, because you're responsible to your plan members, okay? If you run a self-funded plan, you're not responsible to the CEO of your company. You're actually responsible to the plan members. And if you are not being a steward to those plan members, then those plan members have a right to sue you as the plan sponsor. And especially your COBRA folks, because your COBRA folks aren't working there anymore. So if you've got somebody who's like ticked off on COBRA, they actually have great grounds to go after you now for not acting as a fiduciary, because you can't even tell them what a dialysis session costs. So now there are active trial lawyers who are actively going out and talking to people to try to stir these things up, because that's how they generate business. So I'm not trying to be all, doom and gloom and fear and stuff, but we all have to remember who self-funded plans work for. They work for the plan participants.
Yeah, great point. Richard, how have you seen this in practice? You'd referenced difficulty in obtaining data for your clients or getting data that was like, poor quality, lumped together, really difficult to utilize. Like, how has this played out?
Yeah, I think the thing that's important to remember is up at the top, the plan administrators, they own the data. The claims are the responsibility of the plan administrators, the plan sponsor. As Eric's already mentioned, at the end of the day, they are responsible. They might outsource some of their responsibilities, but that doesn't remove the obligations. So their job is to protect the plan and to protect the assets of the plan, which are the employee contributions and the employer contributions. They also have the right to share those data with providers that are reasonably equipped to help improve the efficiencies or save money on behalf of the plan. So anything that they do that is to the benefit of the plan, that typically is saving money, but it might be improving efficiencies or improving service, that's all permissible. And as it frankly is expected as a plan administrator. It references these gag clauses. And I think there was a Q&A specifically about United Healthcare and Aetna hiding behind their network agreements and not carving out. And then historically, they have not been willing to release certain data, certain claims information because of quote unquote proprietary contracts. Well, the 2001 Consolidated Appropriations Act, CAA, did have an anti-gag clause in there. So we're early. I think the first attestations are not due. In fact, I know they're not due until the end of this year. So we will start to see the impact of that legislation on these contracts and on the availability of claims data and disclosure of the contracted rates. But it still can be a challenge. And then I think, to try to address this question specifically about United Healthcare and Aetna, the BUCAs, and BUCA is short for Blue Cross, United, Cigna, and Aetna. Those are historically the large insurance carriers. They all provide fully insured insurance, but they also provide TPA services as well. They are less flexible, and it's less of a legal constraint as much as more of a business decision where they just decide they are not going to allow carve-outs, and you can choose to go somewhere else. Sometimes you can push back. Sometimes the key is to have very good relationships with these carriers and very good account reps that you can work with. In other cases where we have had much better success is where you go to TPAs who have access to the networks. So a UMR that has access to the United network, or Meritain that has access to the Aetna network, are great examples where you can customize your benefits much more so, carve out your dialysis services, carve out pharmacy, stop loss, whatever you want to do. So that typically is what we would do to solve that problem. So I think probably about all for this slide. If you want to move to the next.
Real quick, what I would say to put a fine point on it is, if you request data from a BUCA or whomever, and the response is no, because producing it would violate some confidentiality clause in our network contracts or this proprietary data, that I think will ultimately prove, first of all, I think it's unsupported in law. And secondly, I think ultimately, if and when this does come to litigation, that kind of argument will be systematically dismantled and will not be something that a network or a TPA or whomever is going to be able to use to prevent a plan from assuming its own data. So I would say my advice is to push back, do not get pushed around, right? Insist on your own data. As a fiduciary, not to beat this dead horse, but as a fiduciary, you're not only entitled to the data, you need the data to fulfill the plan's fiduciary duty. There's no other way to do it. And so rather than put yourself at risk, as Eric articulated and as Richard articulated, you need the data. And I think the plan cannot stand or the network cannot stand your way. All right, so let me advance to the next slide here. Richard, how have you seen plans work with documentation and carve-outs?
Yeah. So you're right. I mean, I just commenting on what you just said, I don't think we can overemphasize the fact that the fiduciary responsibility is on the plan administrator. And regardless of the contracts you have, that is where the buck stops. And so not only do you have the right, but you really have the responsibility to own your data and to make decisions based on your data. Plan documents, this is where the rubber meets the road. So at the end of the day, the claims are going to be administered based on the plan documents. And so you have the right to design your benefits in a self-funded plan how you want to, but you need to make sure those plan documents match. So, I guess just reading these bullet points, just in case they're difficult to see on the screen, self-funded plan has sole authority to determine its plan documents. TPAs and other parties may recommend plan documents, but only the plan sponsor has the authority to adopt them. A critical thing, don't assume the documents are correct. I bet you 75, 80% of the documents we review have errors in them. The TPAs, the carriers, they're volume based. They're producing their standard documents, sending them out. They want the work to be done by the plan sponsors and the advisors to make sure those are correct. But it is critical. It is critical that you go through them and you identify those things, especially when you're doing a carve out or something that is non-traditional for them. Typically the SPD is what we're talking about when we're talking about the plan document. As this last point states, you have the right to adopt a carve out for various services. And that's highly recommended when it comes to dialysis because of all the things we've already stated.
Eric, you're shaking your head. Like, do you have something?
Well, and I think that this goes together well with Richard's prior point about the flexibility of TPAs, whether it is UMR or Meritain or another TPA, that, frankly, that, it's like there was like the HMO thing and then there was the CDHP thing, and really the movement to TPAs. I've really seen that, especially over the last 2 years, kind of coming out of COVID, it's like, prioritization, well, we got a gazillion things to think about. And so with the labor market being so tight, it's like, well, there's only so much we can do with plan design because we can't shift any more costs onto the employees. And so they're like, it's really, we got to get creative on how the plan is administered. And frankly, we need a TPA to do that.
Great point. Great point. All right. So moving on, Eric, can you help us understand how plans can force benefits pay and enforce, having the benefits paid according to plan documents?
So again, great information on the slide. Let me go ahead and read it. If a self-funded plan's documentation includes a carve-out, TPAs and ASOs are required to comply. TPAs and ASOs only have the legal authority to administer and determine benefits as provided in the plan documents and the SPD, as Richard just said. Okay, any administrative or benefit decisions which do not comply with these requirements are unauthorized and contrary to federal law, right? It's your plan, okay? A self-funded, now, of course, your choices for administration in the plan, and this was in one of the questions, is that, so look, it's like, at the end of the day, you might have to go out and change, an RFP, right? And guess what? Like that, I mean, I see more and more self-funded employers like doing that. They're like, we get it. Guess what? We're RFP in it. Okay. A self-funded plan must be careful, however, because applying a simple multiple of Medicare, okay, this is where, okay, we're just going to pay, Medicare, 125% of Medicare, 200% of Medicare, whatever. That cost containment methodology to dialysis treatment carve-out invites, basically, DaVita or Fresenius might come after you if you're just going to we're just going to pay 125% of Medicare, whatever. Okay, so the courts may find such rudimentary multiples of Medicare just unjustifiable. And this last bullet point, I think, is the one to really pay attention to. So rather a demonstrated legally defensible cost containment solution for dialysis carve-out is Renalogic's usable and reasonable methodology as demonstrated by the unanimous decision of the U.S. Court of Appeals in the Ninth Circuit for DaVita versus Amy's Kitchen. Okay, so you've got two court cases you got to look up. All right, DaVita versus Amy's Kitchen, fascinating. Okay, it's not literally Amy's Kitchen. It's an organic food company. And again, they did a carve-out dialysis benefit. It was sort of similar to what the Marietta Hospital did. And so DaVita went after them. And DaVita lost again. And so this was in 2020. So you have two losses in 2020 and 2022 that are both tremendously helpful from a legal perspective for an employer-sponsored plan. And again, if you just Google it, the summaries of DaVita versus Amy's Kitchen are actually very easy to understand if you want to look at it yourself.
Yeah, great, thank you. Richard.
Yeah, so we're talking about PPO agreements. PPO networks, PPO arrangements, that's the most popular plan design, or I should say network design in the country these days. They are the broadest networks. They allow for the most flexibility. You don't have to have the old gatekeepers of the old HMO networks. That's probably where you get the most pushback as well. Again, a lot of the questions are about the BUCAs. Those are PPO networks where you're getting the pushback. In exchange for having that big, broad network, they have the most flexible agreements with the providers. And so they try to protect those contracts with their providers. They try to take care of their providers. They are in the volume business of, hey, we want the best discounts because we're going to bring you the most bodies, most belly buttons. And they're going to push back. But the reality is these networks also allow carve-outs, and you should push back. You should expect to be able to design your plan how you want to.
Yeah, great point. And to that point, what we see a lot of times is a question about whether the TPA will administer a carve out, or whether there's an alternative to be had. And so, to be clear, self-funded plans have the right to an alternative third-party administrator for these carved-out dialysis benefits when the primary TPA has some sort of objection or issue or an unwillingness. I think that in either situation where I just articulated, the self-funded plan has an unwilling TPA, or they're unwilling to amend the documents, the plan can bring in its own TPA. In a dialysis context, we call that a dialysis claims administrator. And we work with dozens of plans that will bring in the secondary TPA for the express purposes of just administering the dialysis carve out. So know if you are a plan looking to carve out and you're getting pushback or friction from your primary TPA, you have options. There's creativity, there's flexibility, there are alternatives to administer the benefits, how the plan sponsors determine to administer them that in the best interest of the plan, the best interest of the plan members. With that, let me get to our second poll, which is here. And let me just also bring it up for everyone to see, which is, here we go. Are you currently experiencing resistance from stakeholders when trying to exercise your rights to control dialysis costs? I can see by some of the questions asked, this is particularly salient to some of the people on the call today. And so, hopefully this will be a lively response, but, A, yes, B, sometimes, C, no, not often, D, no, never, and E, not sure. And the response
and I'll just say while you're answering that, just to give you some time to answer it, that I have seen multiple groups that want to go in this direction, and I have had the president of a large national brokerage firm say to me over lunch, he's like, look, a broker and benefits consultant's ability to balance the needs of the employer client and the needs of the carrier is a daily struggle. And so just know that as you're doing this, that there are many brokers and consultants on this call that you're going to be in a position of struggle like that president said. And so there are absolutely employers who are growing to not trust their broker and consultant to frankly be on their side. And so they look to change them. So I made a video called Broker Lapdogs versus Broker Guard Dogs. So just know that as we've come out of COVID, that some employers are like, I need a broker consultant guard dog on my side, because I know that there's a diversity of broker consultants out there, and some of them are lapdogs. And so I know that Richard is a guard dog because of what he's done in the past. And I know that all of you are guard dogs as well. That's why you're here.
Yeah, no, that's fantastic. Great point. And Richard certainly is, a guard dog, and really just a zealous. I put it a different way. I should say, a zealous advocate for his clients, and really a trusted advisor and consultant. So just to publish these results, I don't know if you can see them here. 51% of you are encountering some issue, right? Either often or sometimes. And then, there's a fair bit who are not quite sure. So backing it out, I think the overwhelming majority, if you factor in those that are not sure, are having some kind of difficulty. See if I'm sharing this now, if my controls are working the right way. So look, this is a salient topical issue. I think it's one that you're going to encounter as we're in, this challenging macroeconomic environment and a tight labor market. And as plans are looking to save costs where they can, carve outs, cost containment solutions are critically important. And so as those get implemented, you'll see the friction, I think, increase. But fortunately, as we articulated, there are rights and solutions that you can bring to bear to help your clients. So turning to some question and answer, let me look at some of the things you guys have submitted. It says here, so I'm scanning through, and some of these basically ask the same question in different ways, which are, do you have solutions for situations where the network that a self-funded group uses does not allow a carve out? For instance, Cigna, other ones reference Aetna or Meritain or UHC. The answer is yes, right? There's a lengthy answer I can give you, which I would be delighted to do offline and walk you through our process. The short answer is A, those networks cannot block you or your clients from carving out. Hopefully these 6 inalienable rights have demonstrated that the plan has the right to carve, the plan has the right to its own data, and neither the TPA nor the network can quote unquote disallow or refuse to carve, right? They need to follow along and take direction from the plan, not the other way around. In terms of what Renologic specifically can do to support the plan, we offer kind of comprehensive advisory services, legal service, legal support, if you will, or more like advisory consultative services to help enable the plan to enforce the plan's own rights. And if you have questions about that, I highly encourage you to follow up at this email address below, or to reach out to me individually at svold@renologic.com. Couple other questions here. There are a number of questions around Marietta, the Marietta decision. These are some lengthy questions. Let me put those aside for a minute here, because to read each one is going to take, it's going to eat up some time here. One is just, will the recording be posted and supplied? Yes, for those of you that tuned in late, as a housekeeping matter, this is being recorded. We will post it to our website. We will distribute it to those that registered. And then you should feel free to share it to your colleagues and stakeholders and clients you think could benefit. Couple other questions here. One was, what constitutes predatory pricing in the dialysis market? And I think in the dialysis context, predatory pricing can be thought of pretty simply as this dialysis duopoly, or Big Dialysis, taking advantage of its overwhelming control of the market and the lack of choice in the market to charge self-funded health plans excessive fees for dialysis treatments. A health plan member in a self-funded plan, a commercial plan, who needs dialysis services very often has little to no choice of where to go. And we talked about the Marietta decision. I think in that case, if I'm not mistaken, 100% of the dialysis clinics around the Marietta Memorial Hospital in Marietta, Ohio, were DaVita owned. Like there was just nowhere to go in a 25 or 50 mile radius for a dialysis patient other than a DaVita facility. And whether it's DaVita, Fresenius, or both, you see this across the country. 85% of the services are controlled by those two organizations who are able to leverage this lack of competition, this lack of choice to drive up prices. Another question: are there any precedents for self-funded health plan self-funded employers successfully leveraging these rights? So yes, absolutely. So we mentioned the Marietta case where the hospital carved out dialysis services and applied a reference-based pricing methodology to contain costs. There's also the Amy's Kitchen case where Renologic supported Amy's Kitchen, and where the Ninth Circuit Court of Appeals unanimously found that the way in which Amy's Kitchen carved out its dialysis benefits and the pricing methodology, the repricing or cost containment solution they used, which was ours, was legally defensible, was rock solid, and justifiable in containing excessive costs from DaVita. But I'll also say, there's 20 years of precedent based on Renologic's track record. So Renologic is a more than 20-year-old company. We have helped hundreds of thousands of health plan members and hundreds of clients successfully, carve out and contain dialysis costs using our own methodology. And so in that case, this is real world examples of precedents, if you will, to contain costs. This one I think is probably good for Richard. How do you recommend engaging with stakeholders to foster collaboration rather than resistance?
Yeah, so I think, the first of all, I saw a question in here. I'll answer that question, Scott, but I saw a question here in the bottom I want to talk about as well. I appreciate being called a guard dog. Thank you, Eric and Scott. But the question is, what's the conflict of interest for brokers? And then the idea of bonus was brought up. Unfortunately, there are some brokers that are out there that do try to maximize relationships with their carrier partners because they do get paid bonuses. They might get paid elevated commissions. Firms like my firm, like Marsh McLennan Agency, we do a number of different things because for us, it's very clear. We have one set of loyalty. It's for our clients. And in most cases, we're paid direct fees by our clients. We're not paid through the carriers. We aren't even aware of any carrier bonuses if we are paid bonuses at all. So that doesn't even come into the equation. And I think you want to look for full disclosure on any fees that are being paid, any relationships that might exist, and to try to make sure your consultant, your broker, is always understands who he or she reports to, and that's the client, not the carrier. So I think your question, Scott, was about stakeholders and how do you go about having that conversation? How do you do the carve out when you have pushback? Well, I think the first part, particularly when we're working with middle market clients, in some cases maybe self-funding for the first time, it's helping the clients and the plan administrators understand what their obligations are and what they can do with the data that they have. And then that empowers the client and us to then work with the carrier partners, the TPAs, to try to get whatever data we need. Ultimately, we have the right to those data. So we have right on our side, for a lack of a better way to say that. I mean, we have access to those data. Sometimes it just takes multiple attempts, or it might take leveraging our point of contact up to higher levels within organizations to get those data released. But usually and certainly we've been doing this for a long time. So the carrier partners expect us to ask for those data, and it's just part of it.
Yeah, no, fantastic point. this next question kind of picks up on something you had said earlier, Richard. So it says, what specific strategies can employers use to counter the excessive pricing of big dialysis? So there's two strategies. One is focused on what happens when you already have a dialysis or end-stage renal disease problem in your health plan, and one is for the future. So current state, for when you already have the problem, it involves repricing solutions or cost containment solutions. People often think about this in the context or using the framework of reference-based pricing, RBP, which I think is a little reductivist. At Renal Logic, we have our own proprietary repricing methodology that we developed over 20 years, which takes into account dozens of data points to rationalize high-cost claims and recalibrate them to something more rational, more appropriate, more market-based. Kind of just applying a multiple of Medicare and saying, hey, we just think this thing is, we're only going to pay 140% of Medicare or what have you, invites a lot of trouble. There's been a lot of litigation. It exposes the plan to risks. We don't need to go on that one. To pick up on what Richard said, though, is really more preventative. So I think the best way to prevent or contain high-cost dialysis claims is not to have them in the first place. And that way is through delivering, this is kind of, again, in line with what Eric thinks about and talks about too, which is having preventative services, identifying those health plan members using the claims data that we're all trying to get, who are at risk, who either have chronic kidney disease, which is the precondition before end-stage renal disease, right? End-stage renal disease is the terminal state of chronic kidney disease. And we've done a great couple webinars on this, which I highly recommend everyone checking out. Or it's those that have diabetes, hypertension, all of the comorbidities associated with chronic kidney disease, which ultimately can result in end-stage renal disease. If you identify those members who are the sickest or are trending towards a bad place, and you deliver care management, telephonic specialized nurses, nurse coaching, what have you, and you help those people get their health under control, you help them have better diet, better exercise, you addressing the social determinants that drive the conditions they have, you help them manage the chronic kidney disease to the extent they have it, you can prevent end-stage renal disease, which prevents these high-cost dialysis claims. Eric, I'll invite you to kind of weigh in on that to the extent you have anything more to add.
Yeah, it is incredibly rare for a person to go from completely healthy to then having kidney failure and requiring dialysis. It takes years to decades, and you'll see it in the claims. And so you'll be able to pick up. I mean, that is my reason for doing this. It's because employers have a fantastic opportunity to help these people to not need dialysis in the first place. Okay, being on dialysis, forget about the money. It's a horrible life. Nobody on dialysis is like, oh, this is great. I get to go to dialysis center half a day, 3 days a week. They get infections in their dialysis catheters. Like, it's awful. It's a horrible way to live. And so if something can be done through your job or your spouse's job to prevent that from happening, then that's a huge win. I mean, I'm sorry, as a physician, I'm not trying to get Pollyannish here, but like, there is serious good that an employer or a broker consultant to do to completely change somebody's life. And I would argue, let's do it. I mean, yeah, it takes work. Yeah, it takes time. But so what? What else are you going to do?
Yeah. So on that, I want to thank you two very much for participating and offering such great insight and information. Truly a pleasure. And for everyone who tuned in, thank you very much for joining us this last hour. I hope it was informative for you. Again, we will distribute a recording of this webinar for you to look at later, revisit, take notes from, compare your notes from the live version, and share with your colleagues and clients. I also encourage you to visit our website where you can find other webinars we've done, one with Eric on chronic kidney disease, others around reference-based pricing the market, some on actually the Marietta case that I did with our Executive Vice President of Legal and Risk, John Christensen. And you can also find case studies and other resources there. So thank you very much for joining us today. and we will hopefully see you on the next webinar. Take care.
Bye, everybody.
Bye-bye.